Our next section is glomerulonephritis. Glomerular diseases, glomerulonephritis, and nephrotic syndrome. Now, this section is very challenging for people because most of these diseases are diseases that you wouldn't ordinarily think about a lot. There's some of them, like post-streptococcal glomerulonephritis, that you've thought about before, but a lot of them have tests that you don't think about a whole lot. C. ANCAs, diseases like Alport syndrome. Well, when do you answer these tests? Well, the other thing is that about glomerular disease, what we're going to do is we're going to take each of the glomerular diseases and we're going to get them reduced to 10 words or less for each of them. The first thing about glomerular diseases is to remember that all forms of glomerular diseases, glomerulonephritis, all of them can give you red cells in the urine. All of them give you red blood cell casts. All of them can give you protein in the urine, and by itself that does not help you. All glomerulonephritis can give you red cells, red cell casts, and proteinuria. Now, what is the difference between glomerulonephritis and nephrotic syndrome? Nephritis and nephrotic. The major difference is in the degree of proteinuria. When you develop glomerular disease to the degree of proteinuria, where it's greater than 3.5 grams a day of protein, now we have nephrotic syndrome. Glomerulonephritis, which is less than 3.5 grams of protein, is predominantly characterized by red cells. Nephrotic is characterized by proteinuria. So therefore, although nephritis is characterized mostly by red cells, and nephrotic with an O by protein, the fundamental difference between them is the degree of proteinuria. Which glomerular disease can cause nephrotic syndrome? And the answer is any of them. Because nephrotic syndrome is not based on the etiology, it's based on the severity. It's not the etiology, is it Wegener's or Goodpasture's, Alport, post-streptococcal glomerulonephritis, hemolytic uremic syndrome, TTP, cryoglobulinemia, lupus nephritis, polyarteritis nodosa, Berger's disease or IgA nephropathy. It's not based on which one of those it is. They all could do it. It's based on the severity. It's not the etiology. It's based on the severity. It's not the etiology. It's based on the severity. It's not the etiology. It's based on the severity. Nephrotic syndrome. It's not the etiology. It's based on the severity. I can feel you with me. I feel you. Okay? So say to yourself, I'm now going to make this small and tiny as a subject. I have enough space to learn 10 words about each disease. That's it. A sentence. A sentence. That's it. That's it. That's all we need. Now, nephritic syndrome. Remember, the main thing about nephritic is that nephritic is characterized mostly by red cells and modest amounts of proteinuria. But you cannot say whether it is Wegener's or Goodpasture's, TTP or HUS, cryoglobulins, they all do that. They all do that. Glomerulonephritis. Well, what we have is some sort of autoimmune problem attacking our immunoglobulins, attacking our glomeruli, or attacking our tubules, but mostly the glomeruli. Now, we have edema for 2 reasons. Number one, we have low oncotic pressure in some cases. The other thing is that we have salt and water retention. No one's quite sure exactly why we have a salt and water retention. It's part of the injury of the kidney. One is that you have a low oncotic pressure causing you to have loss of fluids into the third space, into the tissues, but there's a profound salt and water retention resulting in hypertension and edema. Now you see this thing where the hematuria, but you see this word dysmorphic? Dysmorphic red cells means that as the red cells are squeezing their heads through the glomeruli, I got a red cell, I'm squeezing my head through the glomerulus. You know how when you were born, remember when you were born and you got your head squeezing through that vaginal canal? And your head got a little squished into a cone. We're all born a little as a cone head. You know how it is to get your head squeezed through a vagina? Well, the red cell, as it squeezes through the glomerulus, it's like caput. It's like caput for a red cell. Dysmorphic as it squeezes through. Now you see it says proteinuria less than 2 grams because nephrotic range proteinuria is more than that. Why is the fractional excretion of sodium low? Because the intense vasoconstriction provokes a urinary retention of sodium. The same reason that you have salt retention, well, that's why the fraction excreted is low, because you're retaining the salt. Man, you can't have it both ways. If you're retaining it, you can't be excreting it. Now, the single best initial test is always the urinalysis, looking for red cells that are dysmorphic, red cell cast and protein. The most accurate test overall is not a 24-hour urine, it's a renal biopsy. So for glomerulonephritis, the single most accurate for all of them is a renal biopsy. Now, what is the difference between these things? Look at all this stuff. You see, this is why people look at these diseases and they go, forget it, I can't, I won't, I can't learn it, I can't, won't. Look at this, too much information going through my brain, too much information driving me insane. Why, when I was in your position, I used to go like this too. I could pass without needing to know this. Where's the beach? Hey, where's that case of beer you owe me? That's what I used to do. I could pass without needing to know this. So let's make this small and manageable, so it doesn't feel so painful. Let's make this small and manageable. And let's say, well, Wegener's and good pastures, looking at the top. Wegener's and good pastures, looking at the top. Well, what is different about Wegener's and good pastures? Wegener's and good pastures different from the others. Wegener's and good pastures, if you look at this slide, Wegener's and good pastures very close to each other. Wegener's and good pastures are both pulmonary renal, but good pastures is only the lung, Whereas Wegener's granulomatosis is not only just the lung, but it is upper respiratory as well. It's upper respiratory as well. It's upper respiratory as well. Upper respiratory as well. Now, Wegener's is a systemic vasculitis. Wegener's is a systemic vasculitis, so Wegener's also goes into the joints and the skin and the eye, joint and skin and eye and renal and GI tract. However, the most characteristic thing is it's both upper and lower respiratory, whereas good pastures is only lung. Now, if you look at the one just underneath that, you'll see this thing Churg-Strauss. Well, what's the difference between that and Churg-Strauss syndrome? Churg-Strauss syndrome does a very similar thing to Wegener's, which is that it's a lung disease, except Churg-Strauss syndrome, you just have to know 2 words. 2 lousy words about Churg-Strauss. You got enough room for that in your brain, huh? Oh, I can't stand it. I couldn't take it. Not one more bite of knowledge. Oh, no, just one little thin mint, one little drop of information. And the answer is it's characterized by asthma and an increase in the eosinophils. 2 words, asthma and eosinophils. It's also known as allergic angiitis. Why allergic? Because of asthma and eosinophils. Angiitis. That's it. That's it, just one little different thing. One little post-strep glomerulonephritis. Post-strep, now the first thing to know about post-strep is that strep is just the most common infection to cause glomerulonephritis. What other infections can cause glomerulonephritis? The answer is all of them. All of them can cause glomerulonephritis. Strep and staph and toxoplasmosis and lupus. You know, infections provoke an antibody response. The antibodies clog up the glomeruli like Dr. Fish's hair in a bathtub drain. They're just clogging it up. The immunoglobulins. So post-strep glomerulonephritis is because the streptococcal antigens in the surface from a pharyngeal or skin, because remember, skin can cause the kidney problem, but skin can't cause rheumatic fever, is provoking an allergic reaction and toxins against the glomeruli. Post-strep glomerulonephritis. Now give me something different so you can answer the question, which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? What's the best initial diagnostic test? What's the most accurate diagnostic test? What's the best initial therapy? Now remember, this method of looking at this, of saying, what's the most likely diagnosis? What's the best initial test? What's the most accurate test? Also, there's a set of flashcards by me on the same subject, which is to say, here in a box you say, look, anti-streptolysin O, ASLO, or anti-DNase. Well, when are these the answer? You see, you say, when do we answer that? And that's the answer for what's the best initial test to diagnose post-streptococcal glomerulonephritis. Well, what is it that will make me send them? What's going to be different about post-strep glomerulonephritis to make me send those? For instance, good pastures is anti-basement membrane antibodies. Well, what's going to make me send anti-basement membrane antibodies? I see a patient who's got a lung and a kidney, a lung and a kidney, a lung and a kidney. Well, why am I going to send best initial diagnostic test, C-ANCA? Because I see upper and lower respiratory, upper and lower respiratory. Well, what is going to be there to say make me get a DNase? And I'm going to see a child or an adolescent, a child or an adolescent. I'm going to see periorbital edema, hypertension in a child. Are you ready? Tea or Coca-Cola colored urine. Tea or Coca-Cola colored urine. I love this. Medical foods. Kai, can I have a cup of tea colored urine? Oh, I'm sorry, we're fresh out. Can we interest you the Coca-Cola colored urine? Well, that would be fine, but could I have that with a blueberry nevis? Well, as long as you don't mind a side order of anchovy paste aspirate. Well, how about a nutmeg liver as a main course? Very good. Would you like a strawberry cervix on top of chocolate agar for dessert? Yum, yum, yum. Yum, yum, yum. And on top of it, to top it all off, how about a nice cherry hemangioma? Tasty, tasty. And don't forget my cafe au lait spot. Yummy. So the whole point is medical foods. Cafe au lait spots. Von Recklinghausen's disease, yeah. Strawberry cervix, Yes, that is trichomonas. Okay? Tea or Coca-Cola colored urine. What's the tea in the Coca-Cola color about? The tea in the Coca-Cola color is hematuria proteinuria, edema and hypertension, hematuria proteinuria, edema and hypertension, ASLO and DNase. Wow. What's the most accurate test? A biopsy. What am I going to do? I'm not going to do no biopsy. Why would I biopsy somebody who has a brief self-limited disease that you're going to give a diuretic and control the hypertension? Why would I biopsy? It's not like good pastures, which is going to get treated with plasmapheresis. I better get a specific diagnostic test. Now let's look at the IgA things. We have Henoch Schonlein purpura, yeah, Henoch Schonlein, Henoch with the umlaut over the Schonlein, yeah, Schonlein purpura, yeah, the umlaut. That's IgA. And Berger's disease. Now, Americans don't like eponymous names, so we prefer to call it IgA nephropathy, because then at least we know what we're talking about. It's a problem with the kidney. That's from IgA nephropathy. Now, IgA nephropathy happens to be the most common cause of glomerulonephritis in adults in the United States. They're both IgA, except Berger's disease, IgA nephropathy, is only the kidney. Henoch Schonlein purpura is GI problems, skin problems, joint problems, renal problems. GI problems, joint problems, skin problems, and renal. GI, joint, skin, 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 and renal. Whereas Berger's disease is only hematuria. It used to be called benign hematuria until we realized that a bunch of them ended up on dialysis, so it's not so benign. The other thing is Berger's, or IgA nephropathy, happens at the same time, within 1 to 2 days as a pharyngitis. Post-strep is 1 to 2 weeks after the pharyngitis, but Berger's is 1 to 2 days, right away, same time as a pharyngitis. You should also look for it they'll describe an Asian patient. So it's IG Asian. Look for the Asian patient with hematuria. The Asian patient with hematuria, Berger's disease, you must biopsy because there is no specific diagnostic test in the blood. There's no diagnostic test in the blood. You must biopsy. Henoch Schonlein purpura with the IgA. Biopsy? No, because why biopsy something for which there is no specific therapy and gets better on its own? Well, what is the difference between polyarteritis nodosa and these others? Well, polyarteritis nodosa affects every organ in the body that Wegener's does, except the lung. Polyarteritis nodosa, not lung. Polyarteritis nodosa, not lung. Although P-ANCA is okay, it's present in only 20 or 30% of patients. And you can actually get an angiogram in order to see whether you're going to get a biopsy. Vasculitic diseases of the kidney. Wegener's granulomatosis, cyclophosphamide and steroids. Churg-Strauss syndrome, cyclophosphamide and steroids. Polyarteritis nodosa, cyclophosphamide and steroids, cyclophosphamide and steroids, cyclophosphamide and steroids. Henoch-Schönlein purpura, no cyclophosphamide, no steroids. Why? Gets better on its own. You ready? Henoch-Schönlein, no biopsy. I'm not giving it any treatment. Biopsy, biopsy, biopsy. Biopsy, biopsy, biopsy. Why? Because I'm going to give you cyclophosphamide and steroids. I better be sure. I better be sure. I better be sure. Well, I don't need a biopsy. I don't need a biopsy to diagnose lupus nephritis. I don't need a biopsy to diagnose lupus nephritis. So why am I biopsying? I could tell you have lupus by finding an ANA and double-stranded DNA. I could find that you have lupus by finding an ANA and a double-stranded DNA. What am I doing a biopsy for? You're biopsying in lupus because although you could diagnose lupus from an ANA and a double-stranded DNA, malar rash, photosensitivity rash, joint pain, serositis, the other criteria for lupus, the biopsy allows us to know whether or not you should be aggressively treating for a proliferative lupus nephritis. In lupus, the biopsy guides therapy. You're not diagnosing the biopsy with lupus. You know they have lupus. But you're diagnosing whether or not someone has just a sclerotic. Sclerotic is a $5 word for scar. If it's just scarring, there's no therapy. But if there's proliferative disease, horrible, overwhelming autoimmune disease, then you'll give steroids and mycophenolate mofetil. Now, in the previous editions, we would have said steroids are cyclophosphamide. But now we say steroids and mycophenolate. Mycophenolate, also known as Cellcept, is superior to cyclophosphamide in its ability to control lupus nephritis with less adverse effects. Why not just give it to everybody? Because they might not need any therapy. If it's just scarring, they get no therapy. If it's proliferative disease, we need steroids and cyclophosphamide. Steroids and cyclophosphamide. Well, Alport syndrome. What's different about Alport's from all the others? Very straightforward, 2 words. And all you're going to say is congenital eye-ear. Congenital eye-ear. Congenital with eye and ear problems. It is a defect in collagen that allows dislocation of the lens and the eye and defects in the ear. Congenital problem with the kidney and eye-ear problems. Congenital problems with the kidney and eye-ear problems. Hey, boys and girls, what's the difference between cryoglobulins and cold agglutinins? What's the difference between cryoglobulins and cold agglutinins? What's the difference between a cryoglobulin and a cold agglutinin? Cryoglobulins cause kidney disease, and cold agglutinins cause hemolysis. Cryoglobulins cause purpuric skin lesions, and cold agglutinins are associated with Epstein-Barr and mycoplasma. Cryoglobulins is most commonly associated with hepatitis C. Hepatitis C. That's why the treatment is interferon and ribavirin. Cold agglutinins, Epstein-Barr, mycoplasma, hemolysis. Cryoglobulins treat the hepatitis C. You get purpuric skin lesions and renal failure. Cold agglutinins causes hemolysis. That's the biggest difference. So let's look at some of these diseases here and try and get a few words. Cyclophosphamide and steroids, cyclophosphamide and steroids, cyclophosphamide and steroids. No treatment for Henoch-Schönlein. It resolves by itself. Post-strep glomerulonephritis, control the fluid overload. Berger's, very tough disease. Very tough disease. What is the specific therapy that reverses IgA nephropathy? You can't think of it? I can't think of it either, because there isn't any. IgA nephropathy has no effective therapy. You will want to answer steroids. Steroids don't reverse IgA things. Steroids reverse IgE and IgG things. but steroids won't reverse IgA things. Steroids don't reverse IgA things. Steroids, you'd like it to, but it doesn't work. Berger's disease, IgA nephropathy, they get massive proteinuria, you give ACE inhibitors. We did that for proteinuria. Fish oils, believe it or not, fish oils, treating us with fish oil? Fish oil. Fisher oil? No, fish oil. Lorenzo's oil? No, fish oil. Berger's disease, fish oils. If they have a sudden worsening and sudden progression, we'll try steroids. Hasn't been shown to help, but we try it if they have a sudden worsening of proteinuria. What's the proven effective therapy for IgA nephropathy? There isn't any. There isn't any. There isn't any. Now, let's look at some of these diseases. Wegener's granulomatosis. Well, what I want you to notice here, ready? It involves the kidney and the upper respiratory. Upper respiratory. Yes, I know it involves the skin, the joint, the eyes, and the GI tract, but so does polyarteritis nodosa. It causes the skin, the joints. Hey, that could be Hanoch-Schönlein. Skin, joint, GI tract. That could be Hanoch-Schönlein purpura. So if I said GI, joint, skin, and renal, GI, joint, skin, and renal, that could be Hanoch-Schönlein purpura. Well, how do we know this is not Hanoch-Schönlein purpura? Hanoch-Schönlein purpura does not cause upper respiratory problems. SED rate is up. Well, SED rate is up in many of these things. The other name for a C-ANCA is this anti-proteinase 3 antibody. See, the other name for a C-ANCA is an anti-proteinase 3. Now, I know what you're thinking, that you finally learned C-ANCA and now somebody decides to change the name of it. I know it's unfortunate, I understand that. But anti-proteinase 3 is the C-ANCA. Now, the most accurate, though, is a biopsy of the kidney of the lung, not the sinus biopsy. Not the sinus biopsy. In Wegener's granulomatosis, the sinus biopsy has false negatives. So ready? GI, joint, skin, and renal, non-specific. Wegener's, upper respiratory. SED rate, rheumatoid factor, that is going to be the wrong choices. Which of the following is the most important initial diagnostic test? C-ANCA. What's the most accurate diagnostic test? Biopsy. Cyclophosphamide steroids. Churg-Strauss. It's exactly the same as Wegener's, except there's asthma, eosinophilia, and they have allergic reactions. Itchy, itchy, itchy. Eosinophils, eosinophils. But the most accurate test is a biopsy. Wow, I'm shocked. Cyclophosphamide and steroids. Cyclophosphamide and steroids. Churg-Strauss, eosinophils and asthma. Well, good pastures, idiopathic lung and renal disease. Well, idiopathic lung and renal disease, lots of things give idiopathic lung and renal disease. Idiopathic lung and renal disease, that can be a lot of things. However, good pastures, that's lung disease. That could be Churg-Strauss. That could be good pastures. That could be Wegener's. What's the most common cause of hemoptysis in the United States? It's not TB. It's not cancer. It's bronchitis. The most common cause of hemoptysis is bronchitis. Because what causes hemoptysis? Anything that causes a cough. What causes hemoptysis? Anything that causes a cough. So does it cause hemoptysis? Yes, but so does good pastures, and so does Wegener's, and so does Churg-Strauss, because it makes you cough. What's unique? Wegener's, upper respiratory. What's unique? Churg-Strauss, asthma, eosinophilia. What's unique? Good pastures is only the lung and the kidney, only the lung and the kidney. You become allergic to the basement membrane antibodies. Now here's another characteristic thing about good pastures. The biopsy shows here, here's another thing, unique, 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 unique. Linear deposits. Linear deposits. Linear deposits in that good pastures. Linear deposits, deposits in a line on the biopsy. The only one that gives linear deposits on a biopsy, good pastures. That's why when it says here, good pastures hemoptysis, that's true, it does give hemoptysis. And so does anything that makes you cough. Lung cancer, tuberculosis, bronchitis, sinusitis, anything that makes you cough. Now, what's different about good pastures? In addition to steroids or steroids and cyclophosphamide, we use plasmapheresis to get rid of these circulating antibodies. Polyarteritis nodosa. I could say what we said for Wegener's and Churg-Strauss, eye and skin and joint and GI, but it's better to just say not lung. Ooh, here's something new. Here's something new. The association with polyarteritis nodosa with hepatitis B. C also, but hepatitis B more. What is different? What's unique? What is different? What's unique? Polyarteritis nodosa is associated with hepatitis B. It's an autoimmune problem. It's an inflammatory problem. Hepatitis B gives chronicity. Hepatitis B gives cirrhosis. Hepatitis B gives inflammation. Hepatitis B gives the inflammation known as vasculitis, polyarteritis nodosa. What is different? Well, the abdominal pain is there because you're having a vasculitis of the abdominal vessels. The vasculitis of the abdominal vessels gives abdominal pain. Now you see, sed-related anemia is rather nonspecific. The single most accurate test is a sural nerve biopsy. Where is it? That's in your leg. That's in your leg, a sural nerve biopsy. Angiography looks inside the mesentery of the guts and sees a characteristic stenosis and beaded pattern of the mesentery inside the bowels. Polyarteritis nodosa. What is different? What's unique? Not lung. What is different? What's unique? Hepatitis B. What is different? What's unique? Angiography, Pianka. Pianka is only positive, 20 to 30%. Henoch-Schönlein purpura. You have IgA deposited. GI joint, skin and renal, GI joint, skin and renal, GI joint, skin and renal, but not in the lung. Not in the lung and not in the upper respiratory. Not in the lung and not in the upper respiratory. Now, if the question says, what is the most accurate test? It is a biopsy. Most accurate is a biopsy. If the question says, what will you do? The answer is don't do anything. What is the most appropriate action? Don't do anything. What's the next best step in management? Don't do anything. What's the most appropriate action, step, do, management? ¿Qué tú quieres ahora? The answer is don't do anything. It's gonna get better. What is the most accurate? It is a biopsy. Just don't do it. Just don't do it. Now, you see these purpuric skin lesions? How do I know that they are purpuric skin lesions of Henoch-Schönlein purpura? Because I'm telling you. You'd biopsy this and you'd see a leukocytoclastic effect. Leukocytoclastic. That means white cells attacking things. So this is Henoch-Schönlein purpura because those are the skin manifestations. Now, IgA nephropathy, or Berger's disease. Now, Berger, IgA deposited in Asians. Now, you see, hematuria is happening 1 or 2 days after the viral illness. That's called synpharyngitic, as in S-Y-N, not S-I-N, but syn as in same time, 1 to 2 days later. That's pretty much the same time. You get hematuria, but all of the forms of these diseases can give you hematuria. By itself, it's not specific. It's not specific. Now, it used to be called benign recurrent hematuria until we realized it's not so benign if half the people end up on dialysis. Although the IgA level is increased in half, it's not reliable enough to make a diagnosis. You notice that there's no good blood test for Berger's disease, IgA nephropathy. So that's why we have to biopsy. You see, in lupus, we have blood tests. We're biopsying to tell severity of disease. In Goodpastures, we have a blood test, an anti-basement membrane antibody. In Berger's and IgA nephropathy, there's no good blood test. The IgA level is not reliable. Now, the treatment, the fundamental question is this. If the question says, which of the following treatments will reverse IgA nephropathy, the answer is nothing. If the question says that the person has proteinuria, what will you treat with? You'll say ACE inhibitors or angiotensin receptor blockers, because that's what we do for proteinuria. If the question says the person has sudden worsening of proteinuria, you'll give steroids to try and decrease the proteinuria. Fish oil is unclear. Can't hurt, might help. Remember, angiotensin receptor blockers and ACE inhibitors are essentially interchangeable therapeutically. They have the same therapeutic indications. ACE and ARB. Well, these are the IgA deposits. I'm telling you they're IgA. You can look at it and tell me, but these are IgA deposits throughout the kidney. Biopsy, Berger's disease. ACE for proteinuria. If they cough, angiotensin receptor blocker. Sudden worsening, steroids. Fish oils might help. Post-infectious. Any infection could cause glomerulonephritis. See how it says that this is strep pyogenes, but it also says hepatitis or staph or strep or anything. The smoke, the cola, and the tea are the proteinuria hematuria. The smoky cola or tea is the proteinuria hematuria. And you have excellent blood tests to be able to tell you that it's post-strep glomerulonephritis so that you don't need a biopsy. If the question says, what would you do first? You'll say ASLO, anti-hyaluronic acid, anti-DNase. If it says, what is the most accurate? You'll say a biopsy. But don't say that you want to do a biopsy. Say it is the most accurate test, but not necessary. Post-infectious glomerulonephritis will resolve spontaneously in the majority of patients. Therefore, you don't have to give therapy. And believe it or not, managing the hypertension and giving a diuretic is considered part of supportive therapy. Now, remember that strep pharyngitis can give glomerulonephritis or the carditis, but only the pharyngitis can give you rheumatic fever and the carditis. TTP and hemolytic uremic syndrome. TTP and hemolytic uremic syndrome. Now, TTP and hemolytic uremic syndrome are very close to being essentially the same disease. If you have three things with the hemolytic uremic syndrome, hemolysis, the anemia, low platelets, and increased creatinine, those three things are hemolytic uremic syndrome. If you add on two more things to make it 5, TTP is the addition to this of neurological problems and a fever. The single most common association with hemolytic uremic syndrome is E. coli 015787. E. coli 015787. The biggest association, E. coli 015787. TTP, you add fever and neurological problems. Just remember, you don't have to have all 5 at the same time. Ticlopidine has been associated with TTP, and that's why ticlopidine, part of what killed ticlopidine, and we use clopidogrel instead. The management of hemolytic uremic and TTP is the most important thing to be able to recognize the diagnosis. If it becomes very severe, the treatment for both of these is plasmapheresis. Remember, do not give antibiotics for the E. coli. As the organism dies, it's thought to release toxin and will make it worse. Don't give antibiotics. Second point, the platelets. Do not give the platelets. It will make it worse for TTP and hemolytic uremic syndrome. Don't give platelets. Don't give antibiotics. Use plasmapheresis. You see, in TTP and HUS, the platelets are coming out of circulation and precipitating in my brain, in my kidney, in my blood vessels. In my brain, in my kidney, in my blood vessels. The platelets are coming out of circulation and precipitating, and that's what's causing the disease. So don't give platelets. You'll just be causing more precipitation. Now, TTP and hemolytic uremic syndrome, it's hard to understand why the plasmapheresis works. Except this is what causes TTP and hemolytic uremic syndrome. If this is a blood vessel, we know that von Willebrand's factor and factor VIII are stored underneath the subendothelial lining of the blood vessel. We know that platelets are held together by von Willebrand's factor and factor VIII. If those are platelets, we know that platelets are held together by von Willebrand's factor and factor VIII. Now, why is it that all of your platelets don't come out of circulation? Because there is, at the same time, the formation of that primary plug of platelets. There is another enzyme in the body that is destroying that platelet plug. Why don't I become one big platelet plug? Oil can! Oil can! Because I have a metalloprotease dissolving that von Willebrand's factor to release them. TTP and hemolytic uremic syndrome. What happens is the platelets come out of circulation. The red cell is streaming along, zooming this way. It hits that platelet plug and gets destroyed. Boom! Do you know what the equivalent velocity for a red cell is in an arterial, if it was a motor vehicle or an automobile? It would be like driving at about 240 miles an hour, depending on the size of the blood vessel. And it hits that platelet plaque, like you driving across the Washington Bridge, and one of those steel cables that holds the bridge out, and just as you're driving along at 200 miles an hour, you decide to put your head out. Take a look. You hit a steel cable at 200 miles an hour. It will shear your head right off. And that's why the red cell hits that and goes, boom! Smash. And that's called fragmented red cells. Schistocytes, helmet cells, fragmented cells. Boom! That's why you see in a positive smear for TTP and HUS. Microangiopathic, micro, small, angio, blood vessel, hemolytic anemia. Microangiopathic hemolytic anemia. You ready? Von Willebrand's factor and factor VIII make platelet plugs. The platelet plugs are destroyed by a metalloprotease that makes them wash away. If you're deficient in that, you get TTP and HUS. Why do we do plasmapheresis? Because it puts on the enzyme that dissolves the von Willebrand's factor and washes it away. That's what would be happening in you right now. That's why don't give platelets, because it forms more of those plugs. You see, that platelet plug washes away in all of us. Well, why don't we bleed to death? We don't bleed to death because this clot that was created by the platelets, clot creation, is stabilized by fibrinogen. Fibrinogen converts into fibrin, and the fibrin stabilizes the plate plug, preserves the platelet plug. We have thrombin creating fibrin by splitting off a piece of the fibrin, called, interestingly enough, fibrin split products, converts it into fibrin, and fibrin stabilizes or preserves the platelet plaque. Now, fibrin would, in its turn, be destroyed as well and washed away. Except fibrin gets stabilized itself with another substance that stabilizes and preserves the permanent fibrin plaque called factor 13, which stabilizes that fibrin plaque, also known as clot stabilizing factor. It preserves that clot so it can't get washed away. Why don't we all bleed to death? Because the fibrin plug gets stabilized, preserved. Thrombin creates the fibrin plug. Factor 13 preserves the fibrin plug. What destroys the fibrin plug? Plasmin. Plasmin destroys the fibrin plug and turns the fibrin plug into D-dimers. So what we see here is von Willebrand's factor and factor VIII create a platelet plaque. The metalloprotease will destroy the platelet plaque, remove it if you have it. The deficiency of that is called TTP and HUS. Fibrin preserves the platelet plug. Thrombin creates the fibrin plug. Factor 13 preserves the fibrin plug. Plasmin destroys. The plasmin destroys the fibrin plug. Creation, preservation, destruction. Creator, preserver, destroyer. Creator, preserver, destroyer. Where's my good Hindus in the crowd? It's a mandala. Look. Earth is crammed with heaven. Every tree is a burning bush. Those who see it will take their shoes off. All the rest can at least eat the blueberries. Elizabeth Barrett Browning. Earth is crammed with heaven. Creator, preserver, destroyer. Brahma, Vishnu, Shiva. Brahma, Vishnu, Shiva. Earth is crammed with heaven. Every tree is a burning bush. Those who see it will take their shoes off. All the rest can at least eat the blueberries. That is what it is. Going on you right now, a mandala. Creator, preserver, destroyer. Over and over at this minute. So, TTP and HUS act as a deficiency of the metalloprotease. Plasmapheresis replaces it and washes away the platelet plug. Next disease. You see an increased LDH and reticulocyte count with TTP and HUS, but that's not different from any other form of hemolysis. Schistocytes, helmet cells, fragmented cells is not different from any other form of intravascular hemolysis like DIC. High LDH, low haptoglobin, high reticulocyte count is every other form of hemolysis that's not special. That's not special. This is microangiopathic hemolytic anemia. These are fragmented, chopped up pieces of red cell. This is like taking red cells and smashing them with a hammer. It's like taking plates and crashing them against the wall. Broken, smashed, destroyed red cells. This is also known as microangiopathic hemolytic anemia. It's also known as intravascular hemolysis. The reason you can see it is because it's intravascular. If it was not intravascular, you would not be able to see it. By the way, where is extravascular? Where is this place extravascular? I know where intravascular is. It's in the vasculature. Where's extravascular? The spleen. The spleen. Extravascular is the spleen. Wow, look at that beautiful schistocyte, fragmented, chopped up cells. Look, it looks like those, doesn't it? Fragmented, chopped up, chewed up cells. Put my cells in a Cuisinart. Chop, chop. Wow, mild disease, do nothing. Severe disease, plasmapheresis. You see this? This is so important, we're saying again. Don't give platelets. Ready? TTP, ready? Platelets. Oh! Platelets. Oh! Don't give platelets. Cryoglobulinemia. What's the difference between cryoglobulins and cold agglutinins? Cryoglobulins are associated with hepatitis B and C. Cryoglobulins are associated with hepatitis B and C. Cryoglobulins are associated with hepatitis B and C, and cold agglutinins are associated with Epstein-Barr virus and mycoplasma. Cold agglutinins cause hemolytic anemia, and cryoglobulins cause renal disturbance. That's what the main difference is. Now, you get joint pains as well, but any other type of serum sickness can do that. Purpuric skin lesion, but you know what? Antibodies deposited in the bodies can give skin lesions. Why Wegener's give skin lesions. Polyarteritis nodosa gives skin lesions. Hanoch-Schönlein purpura gives skin lesions. That's not special. High sed rate? Wegener's gives a high sed rate. Polyarteritis nodosa gives a high sed rate. Lupus gives a high sed rate. And same with the rheumatoid factor. Not special, not different. You treat the hepatitis C with interferon and ribavirin, and rarely you can do plasmapheresis. What is different? What's unique? Wow, our old friend, diabetes. Diabetes is probably, with hypertension, the single most common cause of ending up on dialysis in the United States. Dialysis is caused by diabetes and hypertension, and it's going to get to only be more so. Did you know that there are 10,000 new diabetic patients every week? 10,000. That's 500,000 a year, and that's the number of new diabetics. What is the single greatest driving force behind the development of so many new diabetics? Obesity. Obesity. We are fatter and uglier every year. And because of it, you get more obesity equals more diabetes. Your pancreas just can't keep up. Your pancreas is very upset. Says, I can only support a 145-pound body and you're 212. And that's what happens to the poor pancreas. Now, diabetes and microalbuminuria. The dipstick becomes positive for proteinuria somewhere around 300 milligrams for 24 hours. That's where it becomes trace positive. Somewhere between 150 and 300. Above 300, 0.3 grams, it becomes trace positive. Under that is called microalbuminuria. Patients are supposed to be screened annually for microalbuminuria. What will you do differently based on that test? What will you do differently based on that test? Microalbuminuria will get ACE inhibitors or ARBs. What will you do differently? ACE inhibitors and ARBs. The other thing is that if you have renal disease, you will get a lower threshold of blood pressure. First of all, diabetes and hypertension should get ACE inhibitors, and if you have a cough, angiotensin receptor blockers. Losartan, valsartan, irbesartan, candesartan, telmisartan, ACE and ARBs, ACE or angiotensin receptor blockers. The microalbuminuria also means that you give ACE or ARBs. If you have a diabetic without hypertension, the microalbuminuria also gives ACE or angiotensin receptor blockers to prevent the progression of the proteinuria. The third thing is, if you have a diabetic who's got microalbuminuria, the blood pressure cutoff is lower at 130/80. If you just have a diabetic who's got a blood pressure of 130/80, anything above that, you will add therapy. Now, I would like a blood pressure of 120/80. However, except for the diabetic or the person with proteinuria, I'm not going to increase therapy until the blood pressure hits 130/80. Now, lupus. You could have everything in lupus from a completely asymptomatic proteinuria to very severe disease. You don't need the biopsy to diagnose lupus. You have double-stranded DNAs, low complement levels. You need the biopsy to guide therapy. Sclerosis means scarring. And if it's scarring, we don't give treatment. Proliferative, more severe disease, steroids, and remember, mycophenolate. The wrong answer will be steroids and cyclophosphamide. The only reason to say steroids and cyclophosphamide as the treatment is if there isn't mycophenolate in the answer. Mycophenolate has more efficacy with less adverse effects. Lupus and the malar rash. Yes, that's how we diagnose lupus, but we need the biopsy to guide therapy. Steroids and mycophenolate, also known as Cellcept. Don't answer cyclophosphamide unless mycophenolate is just not in the answer. Now, Alport syndrome, all you need is 3 words. Renal, eye, ear. Renal, eye, ear. That's it. Renal, eye, ear. Renal, eye, ear with Alport syndrome. Ah, yes, rapidly progressive glomerulonephritis. Well, any of the forms of glomerulonephritis can become rapidly progressive, but you could have a separate form of glomerulonephritis, separate from all the things that we had on the board, that is rapidly progressive glomerulonephritis that is its own separate formation disease. And idiopathic rapidly progressive glomerulonephritis, although it can be associated with ANCA, with anti-neutrophil cytoplasmic antibodies, if this is a glomerulus, the crescent formation means basically you have some dirt stuck around, some hemoglobin dirt stuck around the side. Some dirt stuck around the side. So what ends up happening is that you get some extra formation of crappy stuff around it, and it looks like a crescent moon. Biopsy steroid cyclophosphamide. That means Wegener's? No, because Wegener's gives upper and lower respiratory. Churg-Strauss? No, because Churg-Strauss gives you eosinophils and asthma and atopy. Eosinophils and asthma. Polyarteritis nodosa? No, because polyarteritis nodosa is a systemic disease. Churg-Strauss, Wegener's, polyarteritis nodosa. They are systemic diseases that also affect the kidney. Rapidly progressive glomerulonephritis is only the kidney. ANCA, steroids, and cyclophosphamide. See that crescent or crap around the glomerulus? See that crescent or crap? Crescent moon. Biopsy steroid cyclophosphamide. Biopsy steroid cyclophosphamide. Amyloid. Well, you have any chronic infection and inflammation clogs up your glomeruli and causes you to have kidney disease and glomerulonephritis. It can also deposit in the gut and the muscles and the nerves. The basic thing is this. There's no really good therapy for amyloid. You biopsy it. You might give alkylating agents. Alkylating agents like melphalan and prednisone. Does that look familiar, melphalan and prednisone? Yes, because that's the treatment for myeloma. That's the treatment for myeloma. The major issue is this. The diagnostic test is a Congo red stain to diagnose the amyloidosis on a renal biopsy, abdominal fat biopsy, or rectal biopsy. Here's some key words. It gives neuropathy. It gives a restrictive cardiomyopathy. Restrictive cardiomyopathy, sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis, biopsy, the mostest. Yes, peripheral neuropathy, melphalan and prednisone. You know, amyloid is a huge difficult discussion for people because it doesn't fit together very well. Rectal fat pad, abdominal fat pad, biopsy of the nerves, big tongue and macroglossia, it doesn't fit. Amyloidosis, any chronic infection and many cancers, causing the accumulation of amyloid protein deposits in the body. Where does it deposit? The heart, the tongue, the neurological tract, the neurological system, peripheral nerves. How do I diagnose it? I biopsy. How do I treat it? I have to kill off the white cells that make the protein. Amyloid, chronic infections or cancers. It deposits in the skin, the GI tract, and the nerves. I biopsy it and I give treatment for the melphalan and prednisone for the underlying disease. This is a picture of a biopsy of the amyloid. Amyloid is protein boogers stuck in your glomerulus. You have to stop the production of the protein by correcting the underlying inflammatory or infectious condition. Other than that, there's very little specific therapy for the amyloidosis.